Welcome to my series on revision videos in surgery. Today's topic is solitary thyroid nodule part 2. Okay, this is a picture of a neck showing you the location of the thyroid gland and with a large nodule in the right lobe of the gland. Okay, solitary thyroid nodule is defined as a palpable, discrete swelling within an otherwise apparently normal gland. It is usually benign lesion. 50% of patients thought on basis of physical examination to have a solitary nodule have multiple nodules when studied by ultrasound. Less than 5% of solitary nodules are malignant, and this is especially so in areas where there is endemic iron deficiency. This is more common in women, in fact 4 times more than men, and it increases with age. The solitary thyroid nodule is present in about 4% of the population. The chief complaint of the patient is a swelling or lump in the neck. Pain is usually unusual, but when present, it should raise the suspicion for intrathyroidal hemorrhage or a benign nodule, thyroiditis, or of malignancy. History of hoarseness may be secondary to malignant involvement of the recurrent laryngeal nerves. And the risk for malignancy is related to exposure to ionizing radiation and family history of thyroid and other malignancies associated with thyroid cancer. Okay, these are some pictures of patients with solitary thyroid nodule in the neck. Okay, so yeah, normally they are discrete or solitary nodules. They have clear-cut margins if they are benign, and also they move. If on examination, they move well on swallowing. The most important consideration of a solitary thyroid nodule is the possibility of it becoming malignant or being malignant. The majority of nodules, solitary nodules, are benign and include multinodular goiter, simple cysts, and foci of thyroiditis. Less than 1% of thyroid nodules are malignant, and most carcinomas are indolent, as up to 90% survival at 20 years. These are the differential diagnosis of a patient with solitary thyroid nodule. It can be a dominant nodule of a multinodular goiter, can be a thyroadenoma, thyroid cyst, thyroid carcinoma, and localized form of thyroiditis or colloid goiter. The investigations for thyroid nodules include the thyroid function test, the form of TSH, T3 and T4, antibodies against TSH receptors or other thyroid antigens, radioisotope imaging, fine needle aspiration biopsy, also known as FNAC, and of course, the most important is ultrasound, which is a very important and useful investigation, especially preliminary investigation. Ultrasonography is the most sensitive to detect lesions in the thyroid. It is recommended that all patients who have nodular thyroid with a palpable solitary nodule or a multinodular goiter be evaluated by ultrasound. In many places, ultrasound is, however, is not used as a screening test for the general population. Okay, these are some of the tests that you do: the blood test, the thyroid function test, FNAC, molecular testing, laryngoscopy, and imaging such as ultrasound and CT scan. Okay, this slide shows you the differences between malignant and benign nodules on ultrasound scan. Malignant nodules, the hypoechogenic, absence of halo sign, irregular margins, and microcalcifications, as can be seen here. Okay, there's no halo sign as compared to benign lesions. They got a halo sign here, there's a halo sign here. The architecture of the gland itself is more uniform in benign nodule. And there may be axial calcification compared to intra nodular calcifications in malignant lesions. Okay, this is the ultrasound scan of the neck done with the probe here. It shows you a benign nodule in the right lobe of the thyroid. Here, this is the ultrasound guided FNAC being done. Okay, this is the ultrasound probe, and this is the needle inserted into the nodule and aspiration of cells for cytology. Now, the management of solitary thyroid nodule is first the confirmation of the diagnosis by the test which I mentioned earlier. If it is benign, the patient is observed and followed up, and if necessary, to do a lobectomy if it grows in size or causes pressure symptoms. If it is malignant, the operation, depending on the stage, on CT scan and chest X-rays, is either a lobectomy for early tumors or total thyroidectomy with lymph node clearance for advanced cancers. Whatever the treatment is given, it is followed up with post-operative TSH suppression or in some cases radioiodine. Okay, these pictures are CT scan views showing you a large mass in the right lobe of the thyroid, the left lobe of the thyroid, which is this patient, the FNAC came back as a anaplastic tumor. This is a benign nodule with calcification in the periphery. And here, another malignant lesion, you see intranodular calcifications. However, it looks well encapsulated. This is a flow chart to show the management of solitary thyroid nodule. STN, solitary thyroid nodule, as I said, it is subjected to thyroid function test and ultrasound. Determine it's a cyst, it's most probably benign, so you observe the patient. If it is solid, then you do FNAC to see whether it's benign or malignant. If it is malignant, patient subjected to thyroidectomy or radioiodine ablation followed by TSH suppression. If it is benign, then it is done a lobectomy, more conservative methods. In some patients, the cause is indeterminate, so you subject the patient to genetic sequencing test, also known as a thyroseq. Okay, and this can determine whether it is malignant or not malignant. If malignant, treat with total thyroidectomy. Otherwise, if it's benign, then you may just do a lobectomy. And during this lobectomy, you can do a frozen section and on the table decide whether it's malignant or not. If so, carry out with the appropriate treatment. Thyrosequence uses an innovative technology called the next generation sequencing. It is analyzing the genes which are important or involved in the cancer development. Thank you once again for joining me for this short session. Hope to see you again soon.